Good afternoon and welcome to healthsystemCIO.com's All-Stars panel, Business Continuity Strategies to Help You Minimize Downtime, a webinar tweet chat combo from healthsystemCIO.com sponsored by Iron Mountain. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemCIO.com and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We're also going to be using the Q&A and the polling panel today. So as we're having our discussion, if a question occurs to you, send it in the Q&A box. Leave the default set to all panelists, and we'll look at those later in the program. And we're going to throw a couple of polls out to our audience today, and the polling panel will open automatically when we do that. And you can also see the URL for the deck, which you can download at any time, and that's going to be sent out in the chat box as well. Just so you see how we're going to spend our time today, we're going to go about 35 minutes with our panel discussion featuring Chuck Podesta, CIO at UC Irvine Health, Carrie Stein, Director of Clinical Informatics and EMR Clinical and Ops Readiness Coordinator with Johns Hopkins Bayview Medical Center, and Andrew Norton-Mitchell, Solutions Architect for Data Management at Iron Mountain. So without further delay, we're going to jump right in. Chuck, you want to start us off and tell us a little bit about UC Irvine?
Sure. So thanks a lot, Anthony. Thanks, everyone, for taking time out of your busy day to attend. Anthony said I'm the CIO of UC Irvine Health. We're one of 5 health systems within the University of California system, and along with UC Davis, UCLA, UC San Francisco, and UC San Diego. So we are actually, we were talking earlier, we're actually in the middle of a big Epic implementation, so this subject's near and dear to what we're doing because we want to make sure that once we go live on November 4th, which is right around the corner, that we have our business continuity, disaster recovery plans in place going forward. So we've been doing a lot of work in that area that we can talk about. And we're actually going on UC San Diego's instance of Epic in kind of a Connect fashion, so a very different type of project. But that's our focus right now.
Excellent. Carrie?
Hello. Thank you, Anthony, and fellow panelists, and thanks to all the participants. I think it's a very, very timely topic, and Johns Hopkins Medicine is an integrated global health enterprise and healthcare system. We've got more than 40,000 full-time faculty and staff, and we have not only our 6 hospitals, but also a very busy outpatient business and operations of 2.8 million encounters per year. We've been on Epic outpatient for about 4 years in various instances of various hospitals who've gone live with our with Epic at different times. We've had kind of rolling implementations, and I've been the co-chair of Business Continuity Steering Committee for the enterprise for a couple of years now, and so look forward to talking about this more with everyone.
Excellent. Thank you, Carrie. Andrew, you want to tell us a little bit about Iron Mountain?
Sure. With the other guests, thank you for taking your time out today. Iron Mountain is the world's largest data management company worldwide. We have been managing data in a secure fashion for Fortune 1000 and below companies for several decades now. What we've done here most recently is we've taken the physical storage context and move it into the digital storage. We have something like 90 million tapes under management as well as 68 exabytes. As part of what we do, we make sure that everything is secure and that very consistent in how we deliver, and that's really the secret is security and consistency and making sure that if somebody goes down, we can get them back up and that everything is planned out. So that's kind of the heart of what Iron Mountain does for organizations, with not just for EMR, but for other solutions as well.
Yeah, and that's an important point, and I think we're going to get into that shortly. Actually, we're going to get into that right now. So, Carrie, let's start off with you on this. Obviously, the EMR is the application, the core application here, but what are, in addition to that, what are the most critical applications that you're thinking about protecting?
Sure. So I think when we've done our hazard vulnerability analysis, what comes up most often are our communication devices, as well as our other devices and interfaces that communicate with our electronic medical record and the systems that all manage alarms and other kinds of high-risk systems such as that. And our communication systems is the other important focus of our business continuity planning. So anything like email and all our systems that we use to communicate, even to communicate to people that we're having a problem. So we also, staff and are concerned about payroll systems, our supply chain system, and those are among the top that people have always consistently been concerned about.
Carrie, let me follow up with you. Is there a process in disaster recovery where you discover applications from an enterprise point of view that you didn't even know a department was using as you're trying to catalog everything and make sure everything's backed up?
Absolutely. Absolutely, we've experienced that. I would say that probably 2 years ago, we experienced that 2 or 3, 4 years ago, more than we are now. I would say in the last 2 years, we've gotten very, very good at knowing, where some of the, more obscure sort of research areas where there may have been folks using systems that we may not have been as aware of. But I would say in the last few years, that has really been buttoned up and more clear.
Yeah, Chuck, let's talk a little bit about that. You can't sort of take into account from a disaster recovery point of view what you don't know about. So in addition to the main question, if you want to touch on that issue.
Sure. Well, on the main question, just to add to Carrie, I mean, our analytics is becoming more and more, front and center, especially with population health. So that's come up on the list. Before it was just, reporting. But now it's, front and center with some of the predictive stuff that we're doing and some of the real-time analytics. So that's come to the forefront. And it's also very much connected, to the EHR and other source types of system, medical devices and things like that. The other thing would be on your business impact analysis, which is typically where you start. And part of that is your inventory of all your applications, because you need to figure out, okay, where is everything, what's it running on, is it in the cloud, is it on-premise, and then start going through the impact of that particular application or system being down, and its impact to the other, as Carrie said, impact to the other systems that it may be connected to in some way. Now, a lot of people start and do that, but then, and you create your business continuity plan off of that, but you've got to consistently update it. Otherwise, you will run into the systems that all of a sudden show up, 6 months later. It might be in research, as Carrie said, or in other areas that you didn't account for, not on your inventory list. And then when you have a downtime, you get surprised by those particular systems. So it's really an ecosystem of, keeping that BIA, every time you're doing a test, whether it's multiple times a year, going back and refreshing that BIA so that you can catch these rogue types of systems and that could be out there. The other thing that it does for you is, should that particular system be, in a standalone environment somewhere, this is a way that you can capture some of those, and if they need to be on-premise in your data center, move them, things like that. So they, especially in large organizations, they tend to sneak in, and especially in academic medical settings as well, with a lot of research.
Yeah, Andrew, Chuck made a great point that, it's so dynamic. You could sit there and you could do the inventory and you can do the planning and get your hands around everything, but it's only at that one moment in time that you've really got your arms around everything. And to his point, sometimes it's not even a new system was purchased or decommissioned, it's a connectivity was established between two systems since the last time you looked. And so that may change the plan. So just give me your thoughts on the overall discussion here.
Yeah, so that, Chuck brings up a really good point in terms of doing the business impact analysis on a regular basis. So that needs to be, to his point, something that's done on a regular cadence so that you understand the changing nature of your ecosystem, right? One of the things that we like to focus in on, too, is the workloads and the size of workloads. What we see very often, especially within the larger hospital systems and other, university research facilities, is just gargantuan data set sizes that don't necessarily need to be that big for production recovery. So one of the things that we really work towards doing is helping people basically carve off what's relevant for a recovery, what's really relevant for business continuity versus what can be archived off and retrieved in an as-needed fashion and to streamline things for organizations, because what we don't want to do is suddenly burden a network connection with a mountain of data that's actually not relevant for recovery, that's not relevant for, getting a department back up and running, right? So we want to make sure that, we've sized properly for not just the connectivity, the bandwidth part, but we also want to make sure that the data set size is also relevant for recovery.
And Andrew, it sounds to me like that's something that, do you have best practices that Iron Mountain brings to the table in that, or is it a very collaborative discussion with the client in terms of them deciding and everyone agreeing, okay, yeah, I guess we don't need everything, but here's what we need, and you might have different institutions comfortable with different levels of retention?
Yeah, so it's far much more the latter, right? Because if we look at, even our big framework like HIPAA, right, it's not prescriptive. It's just a framework by which you establish a practice for continuity, for recovery, and so forth. And so what we want to do is make sure that the hospital system itself is comfortable with what is set forth, as well as the different business units. Different business units are going to have different requirements, and so we've got to be cognizant of those. So what we do is we sit around the table and we hash it out. It's very much as much an art as it is a science. Some departments may be perfectly comfortable with 90 days of production retention, where others need a year. It kind of depends on the platform. EHR is one that can be challenging because patient records are often needed quickly, so you need to make sure that, from an electronic health record standpoint, that you have enough back there that if a patient comes in, you can serve up the most recent information very quickly, but also retrieve any older information in a reasonable SLA. So it comes down to making sure that the SLAs are appropriate for the department and the organization.
Great, and you gave us a good segue to the next question, so why don't you take a turn at this, Andrew. HIPAA, give us a little overview or your thoughts about what people better know about HIPAA in terms of what they should be retaining.
Boy, that's a tough one. Yeah, in terms of retaining, it's about making sure that you're keeping the data for the right amount of time, right? So you want to look at the timeline for certain data sets. It's not just about how long you keep stuff, but it's also about getting rid of stuff. Far too often I see organizations that have we're just keeping everything forever because that seems to be the easy thing to do. That's not appropriate, nor is it correct. And so you want to make sure that not only are you keeping the things that are needed, but you're also getting rid of the things that you no longer need as an organization. Unfortunately, in this country and the climate we live in, you can be hurt by keeping data far too long. And I've seen organizations that have kept data beyond its expiration date, and then that data set becomes part of a legal action. Had they gotten rid of it, when they should have, it wouldn't be part of that legal action. So there's risk of keeping things too short and too long. So you just want to make sure that you can hit whoever your auditor is, whether it's a Deloitte or a Price Waterhouse or a smaller smaller auditor that you're adhering to what they say and you can prove it. And that's one of the things that we excel at from the data management standpoint is being able to prove to an auditor that we've got the data and we can do it all the time. We get audited on average once a day, once every business day throughout the year. So we're accustomed to dealing with those.
Carrie, let me get your thoughts about retention and this concept of, important concept of not keeping what you don't need to keep. What are your thoughts about that?
I think that's certainly an issue that we see all the time, and I actually think it's also relevant on the other end. It's relevant in recovery, but if I could just, one of the things I was thinking about is in business continuity planning, and we all have, it just made me think of a couple things with the actual, when there is in fact a downtime, and one of the things that we focus on a lot with unplanned outages are how we do documentation. And where I'm going with this is that people want to replicate the EMR in their downtime planning. And, business continuity planning can be very overwhelming, and this discussion really highlights being very clear in whatever aspect you're planning, whether it's, the situational awareness or the actual outage time or the recovery, but really looking at the core set of what you need. So I'm going a little bit off of the exact question in terms of recovery and focusing in a little bit more on the plans that you have and looking at what you really need to maintain safe patient care and operations. You don't need a downtime form for every single type of assessment you have. There are ways to, because that can just be extremely overwhelming to try to plan for that. And the same goes for in recovery, how much goes back in, how much do you have to manually enter. I mean, that could just be an incredible human resource issue. So a very, very important aspect of business continuity planning is prioritizing. What absolutely needs to be done? Getting rid of old paper forms. On our last exercise, we found old lab order forms. So this concept of getting rid of things you don't need and prioritizing the things you do need is a very common theme throughout all phases of business continuity planning.
So, Carrie, you're talking specifically about what you're going to record while the systems are down, and you're saying you don't need to record every single little thing you do.
No, you do need to record it, but you don't need a specialized form for every, it's the forms, it's more around forms management because to your point and to Chuck's point about, reviewing on a regular basis, every time you create a form that you're going to use for outages, then you need to review it periodically. Mm-hmm. So keeping the forms easy enough for staff to use, they don't have to exactly replicate every single screen in the EMR. But that's where a group needs to come together and really plan for that. So you absolutely have to document everything that's done, every med that's given, every vital sign that's taken. But we have learned from doing this process, first with our legacy system, now with our current EMR, that by getting together with folks who are real experts, content experts, you can streamline the creation of those forms to capture the critical data, all the data that you need, without having hundreds and hundreds of forms, which then become outdated very quickly.
Very good. Well, along those lines, Chuck, let me throw this out to you. When you're trying to envision what you need to be able to, what your systems need to be able to do during an outage, so your backup systems, do you want to envision being able to do everything that you could do when you're up, or do you say, no, we're in a down scenario, so we want to be able to recover some systems and move forward, but we don't need to be able to recall an MRI that was done 8 years ago during this outage. You know, like what are you scenario planning for? What do you want to be able to accomplish in an outage, and what's unreasonable?
So, yeah, the way we look at it is, we'll go to the EHR or the EMR because everybody, you know, definitely understands an outage there. So if we use that as an example, what you have to do is what level of outage before you know what level of business continuity plan you need to engage. So this becomes critical with your technical team in getting communications around when a downtime occurs, because the first question I'm going to ask is, you know, in our case, is it a level 1, which it would be 0 to 30 minutes estimation. Now, a 0 to 30 minute estimate for a downtime, that could be, you know, rebooting Citrix servers, something like that, you know, the problem is known and it's not going to take a while. Well, basically, communication out is just hold tight. You know, it's going to be less than 30 minutes. So you're not going to really do anything from a business continuity standpoint. In the case of Epic, you would just go to their PCs that they have, their downtime PCs, and, you know, it's a read-only type of thing, and you'd pull information off of that, and you'd be all set for the 30 minutes. So, again, if it's 30 to 60, then another plan kicks in. And if it's over an hour, or 60 to 90, or over 90 minutes, or it's an unknown, then you've got to kick in a more higher-level business continuity plan. So that's the way, and then when it comes to pulling the different information, you know, if it's 0 to 30, you don't have to worry about that 8-year-old MRI. If it's going to be greater than a few hours, you might need to know about that. So that's the way you got to break it down. It's not just the system's down; it's how long will it be down. That will drive. So it's not a single business continuity plan. It's multiple plans based on the timing. So I think that's critical when you talk about if you just have a one-size-fit-all business continuity plan for every time you go down, that's not going to work. People are going to work harder than they need to in a lot of cases, and in some cases you might miss something.
Very good.
Chuck,
very good.
This is Carrie,
and
I
Carrie.
couldn't agree more. Sorry, yeah, I couldn't agree more with that. I think business continuity plan, again, it's really trying to categorize the amount of time, categorize the root cause, and then categorize the impact, so you can focus, really target your plan so that you're not wasting people's time and not putting people at risk unnecessarily, patients at risk unnecessarily.
Very good. Andrew, let's talk about SLAs. As the service provider, the vendor, you're obviously entering into SLA agreements with your customers. So they've got to meet SLAs, so we'll talk about that from the perspective of Chuck and Carrie. They've got to provide service to their clinicians and the employees of the health system, and if they're using you, then you have levels you have to provide to them. So talk a little bit about that and maybe any advice you can give to those hospital folks on handling their SLAs internally and then their SLAs with vendors.
Sure. So I think, you know, Chuck and Carrie have done a really good job of, you know, kind of spelling out things that need to be thought about. And I think one of the things that Carrie hit on very, very well was being very clear on the documentation, being clear on what the expectations are. You know, that's not only important internally, it's also very important with your vendor as well, so that when you're speaking with your rep, he or she clearly knows what is expected of him. One of the ways that my organization operates is, you know, we are able to sign business associate agreements, also known as BAAs. And what that means is that we work on your behalf so that we become your arm, which is a little bit unusual, especially for an organization that's transitioning basically from on-prem resources to distributed or even cloud resources for backup and recovery, right, for business continuity. So as part of doing that, one of the things that we do that I think makes customers very comfortable is, one, we spell out what our back end is and historically how quickly we've been able to come up. Two, you need a vendor who is willing to go through testing, is willing to prove it through, to Carrie's point, clear documentation of what's happening and what would happen in the event of a DR. So testing is always always important no matter what. And then finally, we will be we're a vendor who's willing to take the financial risk that if we can't meet an SLA, we actually compensate our customers for that. So those are the things that we do as an organization to build trust with our different customers, right? So, and then there's the other things like all the security statements and being able to work through network security and those sorts of things that we do with everyone.
Very good. Chuck, let's talk a little bit about this SLAs issue. I know that sometimes in health systems, the technology unit is actually pulled out and made a separate company, almost a separate entity that then provides services back to the health system. And then I think you do have formal SLAs. I don't know if probably most technology departments and hospitals don't, but then you've got the SLAs with your vendors. Just take me through that and some advice you can give our listeners here about how to handle all that stuff.
Well, I think that, me personally, I think that's why we need to get out of the data center business. When you talk about just the disaster, not the business continuity side, but the disaster recovery side, is we need to get out of that business. It's not our core competency. It has, the expertise of vendors out there is much greater than what you can hire on your staff. And so for me internally to, have my CTO pull his team together and come up with SLAs for our customers, they don't even know the first thing to do about that. And so you've got to bring outside resources in to do the business impact analysis, help them with the disaster recovery plan. The next step to me is just getting out of the data center business. For example, we moved, when we go live with Epic, we're actually going live in Wisconsin at their data center and in a private cloud type of situation with them, and we have SLAs with them for uptime and things like that. And you just send that risk to just transfer that risk to another vendor who knows how to do this stuff and knows how to manage SLAs, and as Andrew said, has ways to not only manage SLAs, but if they don't hit them, compensating the customer. How do we do that? How do we compensate our customer if we don't hit SLAs from an internal standpoint? It's that's impossible for us to do. So that's really my push is let's all get out of the data center business, and I think healthcare will be much better off.
All right, very good. We're going to have our first poll here now. You should see that open on your right. How often are your EHR contingency plans reviewed? And you've got some different options there, so go ahead and take that poll. And we will then get that in front of our speakers, and we'll see what they think of how everyone's doing out there. So we will get back to those results, but go ahead and take the poll. We'd appreciate it. Talk about your current EHR contingency plans. What do they cover? When were they developed, and how often are they reviewed? Carrie, you want to start us off?
Sure. If it's okay, maybe I'll start with how they were developed.
Absolutely.
And there were, we have a lot of inputs to that. So emergency planning, the Office of Emergency Management, and we work very closely with that group, really took the lead on making sure that we were kind of broken down into departments and sort of key operational areas, and that they had a structure for putting their emergency plans together. Clinical informatics and IT, of course, have input into this, and in fact, I believe there are colleagues on the line from Hopkins who know a lot more about our DR plans and testing, but that all is another part of the development, and that has evolved tremendously. In fact, we just completed very successfully some DR testing across the enterprise. And then there are clinical and operational considerations for the safe care of patients. So that, again, is departmental, looking at your high-risk workflows, right? So medication administration, admission, discharge, transfer, medication reconciliation, all those kinds of processes that really go by department, and then there are interdepartmental like supply chain management and registration of a patient without identification, all those kinds of things. So it's very similar to when you go live with a clinical system. What are the high-risk workflows that you think about? Those are the same ones you want to start listing in your business continuity plans. Then there are regulatory considerations. We have CMS now with guidance, and I was just listening to a talk earlier today. The state of New York has different states have requirements, and the state of New York has requirements around making sure that people know that there's a business continuity plan, and specifically related to how patients are moved. So we know that that's also one of the other inputs. And then there are vendor recommendations. And vendor recommendations are just that. They're recommendations. They may recommend hardware, and they may recommend, as Chuck mentioned, these business continuity access reports and certain workstations that you should have connected to emergency power. So those kinds of things are all inputs to the business continuity plans, as well as organizational priorities and prioritization of various patient care activities. And then in terms of what they cover, so we could spend a whole webinar on prevention. So we do a lot around prevention, but if you just are focusing on the preparation itself, it covers the training requirements. We have requirements for how people are trained and what they're trained in from a clinical and operations standpoint. And more we're thinking in terms of training about, a workforce that really hasn't used paper records. So that's another component that we have to pay attention to. And we practice. We've done several drills at both entity-based and enterprise-wide. And practice is an important component of our planning, and as well as I mentioned, forms and reports and the actual tools that we use, workstations that can work when the network is down, emergency power supply, walkie-talkies and other kind of communication devices are all part of that plan. And it all goes back to, as Chuck mentioned, the business impact analysis. What are the things you're worried about? And then how are you going to mitigate those concerns? From a technical standpoint, setting up the infrastructure, and then of course, again, I mentioned communication before, but the command center planning, working with marketing and communications, because there needs to be a plan for managing the media, working with the help desk. So I've named a lot of things. Maybe I'll just stop here, and then, of course, so we can return. Maybe I know you've told people about how often they review their plans. I can talk about that if you'd like as well.
Sure. Excellent. Excellent. Chuck, let's get your thoughts on the question there, or anything Carrie touched on.
Yeah, Carrie made a huge point. And, in the past when you did the business continuity, disaster recovery, it was an IT thing. You did it in a silo fashion. But now everything's interconnected within healthcare, and so you have to tie it to your emergency preparedness overall plans, and tie it directly into that, because it just, the electronic health record means so many things now to patient care. And so I think that part is huge. We do the same thing here, even though we used, we brought in outside expertise to help us with our BCDR plans, but those fed directly into the overall emergency preparedness plan. And then from a standpoint of reviewing, well, whenever the emergency preparedness plan is reviewed, which is driven by state law and federal law through CMS in some aspects, that we do our review as well. So it's all interconnected and tied together in a seamless way, rather than being in a silo fashion. So I think that is huge. If you are an organization right now that your BCDR plans are separate from your overall emergency preparedness, that's a mistake.
Very good. Let's take a look at our poll results. Andrew, 63% said they look at they review their plans annually. Is that a best practice, or should it be more often?
So I would say in the larger IT industry, that seems to jive, right? 63% of people, or even more really, do an annual. I would say given the nature of what a healthcare organization does, I think it should be semi-annually, quite honestly, just because it's a critical service to the public, even if it's a private hospital, right? So I think a hospital being able to run and be sure that they can do it, that it happens at least for those tier 1 systems that can't go down, those need to be semi-annual tests, and then maybe everything else is just annual after that, right? You know, a couple things, Carrie did a great job of like really covering, the best practice, which is, the best disaster recovery is the one that you prevented, right? And so prevention is kind of a big thing. A couple things that came to mind in terms of, pitfalls that I've seen in the industry is, leaving that continuity in DR testing just to IT, right? So one of the things that I've seen is that, IT says, okay, we're going to do a DR test. They bring up the system, the database on the back of it that feeds into that system, and they say, yep, it's up and it's running, but never have an operator, the person who actually interacts with that EHR platform, test it. And so I think one of the things that I see that as missing in the industry often is getting the actual business unit, the actual application operators involved in the DR testing. Now, that's a tall order, right, because they all have day jobs too. But I think it's important, especially in the medical industry when we're serving the public, that they're involved with it to assure that, once that system is brought back up, it's usable. So that's a big deal. The other thing that I've seen where we've had challenges are regional disasters. If you're a large hospital system that has multiple hospitals within a region, it's not a bad idea to cross-train people to work at other facilities as well. That's one thing that Iron Mountain that we do internally is that if we have an outage at one location, we can send people to another location and they're already familiar with that facility and how things are going to run so that they can move from one location to another and get things up and running, right? Because if we look at a regional disaster like a tornado here in the Midwest, oftentimes, the people who work at that hospital have to be gone and be taking care of their own family. So if you have another hospital across town or maybe a couple counties over, if you can send some staff to that facility and let them run while things are being sorted out, that's also a helpful practice. So those are two things that I see as lacking in the industry. The first, I think, getting the operators involved in the disaster recovery business continuity response, pretty low bar. The other one, which is getting people cross-trained at different locations, higher bar, but a really good practice.
Carrie, your thoughts on what Andrew has covered or the overall idea of how often people should be reviewing their contingency plans?
Yeah, well, I'm going to go right to your last point, Andrew, the cross-training at other sites. Wow, you said that really, you put that very well. We had a situation of one site going down, about a year ago, August, and now they weren't necessarily cross-trained, but some of them knew how things worked at other places, and because we were all on one system, yay, it made it easier for us to help each other. It was amazing. And had the situation continued longer, and I will put in a plug for working on long-term outage planning, we even started to formulate a plan on how we could help more. So I think that's a great next place to be going. I think that semi-annual would be great. I think we really struggle with even getting the annual one done. And I think what we need here is to help make all of these things happen as they should and to keep raising the bar is for leadership to be very, very involved. We're fortunate at Hopkins, we've got two executive our sponsors for business continuity planning, Charlie Ruland, our COO, and Stephanie Reel, our CIO for the health system. And because they are so visible and so behind this, we have nearly 100% participation in our exercises, in our, people
doing their plans and that kind of thing. And now that we've moved the DR piece over to also the business owners doing this, we need to have leadership also telling people that, hey, this is really important. You got to pay attention to that email you get about testing for DR. So I think leadership is really, really key. And we've got some strategies for doing that. If there's time, we can talk about that. But I just wanted to bring out that point too. And having leadership behind you for doing this and having this really be a top-down organizational priority is critical.
Chuck, there's a lot of good stuff there.
Oh, yeah. Now, I'll comment on Andrew's point about the operators getting involved. One of the things that you have to be careful of is, you get the system back up, and it's like, wow, we got it back up. Depending on how long you're down, everybody's relieved, and you turn the system on. You have the tendency that you want to do that as quick as possible, but Andrew's right. You've got to get your operations together. You've got to come up with some sort of priority as to how you're checking the EHR, the system, to make sure that it's intact, that there aren't corruption of data. So maybe you start with registration and scheduling and into the rev cycle, HIM, have them go through their pieces first and sign off that everything looks good, then maybe to move to the OR, then to, nursing. So you have these all kind of cadence of or cascading events that occur. It could add another hour to your downtime by doing that, but you'll save a lot going forward by getting everybody involved and getting sign-off so that when you do turn the system on, it is in a state as it was before it went down, as opposed to data corruption, which could be caught and then fixed before you add to the problem, going forward. So that's my comment.
Very good. Very good. Carrie, let's go with you. Let's talk a little bit about scenario planning. Does this come into play with how you prepare? Do you go through different scenarios and say, if this, then that, these type of things?
Absolutely. Yes, absolutely. And where we do a lot of the scenario planning, first of all, it's in our business continuity plans. For network outage, do this. For, different kind of power outage, do that. So we have that kind of planning, and that was put together with a lot of help from our directors of IT and our IT at JH group. So that's, that really was at the very beginning of our most recent efforts. And then for our exercises, which we did a enterprise-wide exercise January 24th, and we had a scenario that was mimicked the scenario that we had just about a year ago, where we had a power outage in the data center. And so this helped, so we didn't create a whole new scenario. Let's just stick with what the situation we had and how could we do better and how could we make the situational awareness better, the actual implementation piece better, and then moving on to data recovery. So I did through the recovery period. So and then we had, and then we've tried to, kind of keep those scenarios not too complicated, because it's kind of hard for people to wrap their head around what the actual impact is. So we keep them, so a power outage, a network outage, a local outage at the hospital, because then you might have, as Anthony has referred to, you might be able to rely on other resources outside of your specific hospital. So we do scenario planning, particularly in the practicing. When we have our local simulation exercises, then we go to specific units and we ask them about their workflows. And if there were a power outage, what would you do? And, and where are your flashlights? And, really trying to, and we have a set of questions that we use for those kinds of exercises.
Andrew, do you recommend this type of scenario planning?
Absolutely. The answer is that simple. Like it can't be understated, or excuse me, overstated how important it is to run through scenarios. What I find, Iron Mountain, we respond to disasters all over the world on a weekly basis. Some of them are localized, some of them are regional, some of them are just point issues. The amount of stress that is incurred by employees when there is a disaster of some sort, whether it's as simple as an IT outage or an actual, building damage by fire or whatnot is amazing. And the practice that happens through those scenarios there's a direct relation from the practice ahead of time. If people have practice, if people know what they're supposed to do, it takes a lot of the stress away. So it's absolutely important, whether it be for, you know, what I do, which is, backup and recovery of IT systems. You know, that's where my limit is, to what Carrie talks about, which is a much broader response throughout a facility, and having people know where their flashlights are, to other groups knowing what they need to do to bring a server up is absolutely critical, because it removes stress. It also ensures that there's a higher likelihood of success of recovery.
Chuck, this is a little bit like insurance. It would be great if we had an unlimited amount of insurance, but insurance costs money. So my point here is that when you're scenario planning, how out there do you want to get? I mean, a nuclear bomb hits California. I mean, you could spend a lot of money having a data center, all over the world, but I'm sure Iron Mountain could help you with that. But anyway, go ahead.
No, I mean, you really have to look at, what are the risks and what are the chances of a certain event occurring. But, in California, unlike, I came from Vermont, I didn't have to worry about wildfires and earthquakes in Vermont. But I do in California, and this last week at this time, we had a fully operational command center because we had a wildfire, which you probably heard about on the news, about 15 miles from the medical center. So we were sitting around the table talking about potentially evacuating the entire hospital at some point. And,
wow.
And those are real scenarios that unless you practice something like that, or earthquake would be of a similar vein, you're not going to be prepared when these things actually happen, and which did occur, a little over a week ago. So it just goes to the importance of not only having your business continuity disaster recovery plan up to date, but also tying it into that emergency preparedness so that you're at the table and you're making contingency plans in case you've got to move patients. And then, what happens if you've got to abandon your data center, how you're going to run operations and, keep things moving, during that particular time. So these are all things that you have to test and discuss and plan for and make sure they're up to snuff.
All right, great. We got a couple of audience questions here I would like to get to. First question, my organization has an emergency preparedness team that focuses more on business continuity. I work in the IT department and focus more on service continuity for applications, but I focus more on disaster recovery and system availability for applications and infrastructure. Do other orgs have a similar structure? Chuck, you want to take a crack at that?
The disaster recovery is definitely led by my CTO, my IT team. Their job, as Carrie mentioned earlier, prevention is a big part, so they need to come up with, the data center strategies, the failover procedures and technologies to really protect the organization from a DR perspective as much as you can, based on the cost. But they are part of the business continuity process as well, and tied into the emergency preparedness. So I still view it as it's different people that are involved, but it's still one team that needs to get together on a regular basis because you can't have DR sitting out there as a silo, business continuity being a silo as well, and expecting communication to go back and forth in the way that it needs to. That needs to all be tied together under emergency preparedness.
Carrie, your thoughts on that question?
Completely agree. Very well put, Chuck. And ours is similar. And then we come together in places like the Business Continuity Steering Committee, where we have terrific participation by our IT folks, clinical informatics, business owners, and we talk about this. And I think a couple of years ago we didn't know each other, so it's really been really good collaboration. To have the technical folks working directly with the training folks is new, and it's been just terrific learning opportunity for everybody.
Excellent. We got one more audience question. I'm going to give this to Andrew, and then we're going to wrap because we're just about out of time today. Great discussion. Andrew, if someone is using EHR, would the assumption be the hospital or others don't have to worry about disaster recovery because the EHR service provider is backing up and giving redundancy for the EHR data?
Okay. So the question is, like, should you trust that? Is that maybe fair?
Let's just assume, yeah.
You know, so my answer is trust no one, right? So what I would say is if you've got and that includes me, right? You come to me for a service, don't trust that I'm saying it. Ask me to prove it. Right. And that's what I would say with your service provider. They may be an excellent service provider. They may be, you know, at the top of the game in the nation or even the region, but I would still ask them to prove it. You know, show me that you can do this. And it's really important that that provider can show you that they can, if, you know, the primary goes down, they've got a failover that comes up. Also have them prove that what if you lose both? How does that organization recover from that scenario? You know, and that, you know, kind of comes back to the reason why, you know, as an organization, I'm available to sign a BAA, and I will compensate somebody if they go down, if I miss the SLA. So make somebody prove it. And if they're a good organization, they'll say, they'll have a little, you know, have a little bit of swagger and say, fine, I'll prove it, right? So, you know, somebody who can prove it won't be afraid of it.
Yeah, and to Chuck's point about transferring risk, you're paying to transfer that risk, and the vendors that are willing to take that on and sign those agreements, you know, should make you a little more comfortable. So that is about all we had time for today. We certainly could have gone another 45 minutes and double webinar, but everyone's got to get back to work, I assume. When you close out your WebEx window, please take a moment to answer our post-event survey. For those with continuing education interest in today's event, attending our webinars gets you 1 CEU towards the CHIME CHIO certification program. If you make sure you let CHIME know you were here, and if you've asked us to do so, we certainly will. You'll receive an email when our archive recording of this event has been posted to YouTube. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox from our team. You can go to our website to see our upcoming schedule of events. So with that, I want to thank our panel, our excellent panel, Chuck Podesta, Carrie Stein, and Andrew Norton-Mitchell. I want to thank Iron Mountain for making this excellent conversation possible, and I want to thank you, our attendees, for always joining us. So with that, everybody, have a wonderful day. Thank you.
Thank you.